Kali, we give another couple minutes or we start? Just let me know when.
I think maybe we should just start. We've got people who've arrived on time, so let's respect that and get moving.
Perfect. And thanks. Dear friends and colleagues, before we begin, I'd like to inform you that English-Spanish simultaneous translation is available for this webinar, and you can access it by clicking the interpreter button on the toolbar below. I'm Alexei Kulikov, the Deputy Head of Secretariat for the UN Task Force on NCDs, and I'm pleased to welcome you today to this webinar, which is called Action Across the UN System to Deliver the 10 Recommendations of WHO and UNICEF Global Report on Assistive Technology. The webinar is jointly organized by WHO Team for Access to Assistive Technology and the Task Force Secretariat. Task Force partners with assistive technology colleagues around national work on assistive technology, including developing investment cases and also operationalizing the call to action for assistive technology in humanitarian settings. Assistive technology is an umbrella term that includes products and related services and systems that support people with disabilities or functional inabilities perform actions that would otherwise be fully or partly unembraceable for them. For example, wheelchairs, crutches, canes for mobility, hearing aids, and spectacles for the neurosensorial sphere, but also digital assistive technology for cognitive or communication impairments. People with non-communicable diseases are an important group of users for assistive technology. Some examples are that people with diabetes might need a diabetic footwear, or people with Parkinson's disease who may need mobility solutions. Overall, there is a huge demand for assistive technology nowadays. The WHO estimates that there are 2.5 billion people globally who are in need of at least one assistive technology product. And this statistics, due to the aging and growing prevalence of NCDs, is expected to grow to up to 3.5 billion by 2050. And the unmet need and polarization is also huge, with estimated access to assistive technologies of up to 90% in high-income countries, against only 3% in certain low and middle-income countries. The 2022 WHO UNICEF Global Report on Assistive Technology has been a response to the 2018 World Health Assembly resolution, which urged member states to take action to improve access to assistive technology. And this webinar stems from the last 23rd Task Force meeting that formalized the commitment to explore and strengthen collaborative opportunities between the WHO assistive technology team and other UN agencies, members of the task force, to implement the recommendations of this AT report. We received a number of confirmations from the UN task force members for today's webinar, and we see that many already joined, and we appreciate your interest in this topic. And we hope that this webinar will serve as an opportunity to foster new and impactful collaboration. And at this point, I hand over to my colleague, Ilaria Karatsa, who will walk you through the agenda and introduce our first speaker for the day. Ilaria, over to you.
Thank you very much, Alexei. Good day, colleagues. Today's webinar is organized into three main sections. We'll have an initial presentation by Kylie Shea, who is WHO team lead of the Access to Assistive Technology team, providing an overview of the WHO UNICEF Global Report on Assistive Technology with a particular focus on its 10 key recommendations. In the second session, our colleague, Dorothy Boggs, will initially introduce the three case studies for the day. And we'll have the pleasure to hear three distinguished speakers from Egypt, Colombia, and the Ukraine, respectively, whom we warmly thank for joining us today. In particular, we have here with us Dr. Ahmed Azab from Egypt, will provide insight into their work related to recommendation 3 of the report around building workforce capacity. followed by Mr. Oscar Marin Diaz from Colombia, who will share their experiences around recommendation 6, focusing on data collection and assessment. And last but not least, by Tetiana Barishok, coordinator of the Ukraine 8010 Attack Project, who will report on their work related to recommendation 9 of the report, that is about the provision of assistive technology in humanitarian settings. The last session of today's webinar will be dedicated to a Q&A session that will be moderated by Nick Panatvala, head of the Task Force Secretariat. Without further delay, I now hand over to our first speaker for the day. Kylie, the floor is yours.
Thank you very much, Ilaria, and thank you, Alexei, and also warm thanks to the task force for actually coordinating this webinar. Dorothy, who you will hear from briefly today, thank you to your background work on pulling all the speakers together. I really appreciate it. So, as introduced, I'm the team lead for access to assistive technology here at WHO, and I happen to be an occupational therapist by my training and background, and I have over 35 years experience in supporting countries to strengthen their services around access to assistive technology, as well as to disability services and rehabilitation. So that's sort of where I come from. Now, what I would like to do is just give you a really quick snapshot of the key messages of the global report, where it came from, how we gathered the data, a few key messages, and then I will talk you through the 10 recommendations. I'm going to go at a fair pace because I really want to get us to that Q&A and also make sure there's enough study for our case, enough time for the case examples, but I do want to respect the translators as well. So I'll see what I can do. All right, so I'm going to start off with the first slide, Dorothy, thank you, which shows a real collection of different assistive products, as well as a range of people doing different tasks in a whole range of different contexts. And really, this is just a framing slide for us to all really understand that when we're talking about assistive technology, it is a very diverse field. It encompasses the needs, the functional needs, and supporting the functional needs of people of all ages. It's relevant across sectors. It's relevant to people's participation and inclusion in access to health, in education, social welfare, livelihoods. And it's also relevant for people with disabilities, but also older people who are experiencing functional impairment, perhaps for the first time as they age. It's also relevant for people who have a health condition and are experiencing functional impairment because of that. And it's also relevant for, for children who are accessing school and experiencing learning difficulties and so on. So it is really, really broad. And sometimes there is a little bit of a tendency to think assistive technology, we must be talking about disability programming. It's much broader than that, and we really need to maintain that broad framework. So on to the next slide, Dorothy. So as Alexei already introduced, the global report stemmed from the first ever World Health Assembly resolution on assistive technology, which was adopted in 2018. And one of the asks to WHO within that resolution was that we prepare a global report on the status of assistive technology, who has it, where's the, how large is the need met, what might be the inequities that we need to think about, what are the barriers, and so on. We prepared that report in collaboration with UNICEF, which was really deliberate to make sure that we are taking this work beyond just WHO and bringing in our UN partners to support on this issue. The report was launched in 2022, and really I just want to flag that I think when that report was launched, we really started to see a ramp up in interest in the area, and the words in the forward from our Director General and the UNICEF Executive Director really spelled out this point that access to assistive technology really does deserve greater attention now than ever before. It really highlighted the importance of assistive technology in terms of enabling access to education, participation in the workforce, independence, aging with dignity, the fact that it is an empowering and an enabling force, and it is a precondition for realization of the Convention on the Rights of Persons with Disabilities, but also the achievement of the Sustainable Development Goals. So it is when we think about it in the context of the Sustainable Development Goals, I would say it is everybody's business. Next slide, please, Dorothy. So with the global report, we obviously needed a tool with which we could gather data, and we at WHO have been developing a number of different tools that we have put into a data toolkit for assistive technology. That includes a situation analysis. It includes a household survey called the RATA, Rapid Access to Assistive Technology Assessment. We also have progress indicators which are sent out to member states every 4 years to enable us to report on the resolution. And we now have, not on this slide, an impact tool, which is going through the final stages of piloting at the moment. The data toolkit was used quite comprehensively, in particular, some of the situation analysis reports, but this rapid household survey, in order for us to get the results that you would see in the report. And through the RATA survey, we surveyed over 350,000 people across 29 countries where we had population representative samples and a number of smaller subpopulation samples as well. We also used the progress indicators to get a really good sense of the systems and the supports in place for assistive technology. So now I want to just take you through some of the key findings, and these are really headline points because I really, if you really want more data, go in and have a good look. It's well explained in the global report. If we can go to the next slide, Dorothy, and then just try and keep up because I'm going to move through these quite quickly. So we've already seen this major headline figure around 2.5 billion in need and 3.5 billion by 2050. It is worth noting the graph on the right-hand side, which shows that that data is, if you split the data from including glasses or spectacles as an assistive product, you see the blue line. So that's the really high figure. And then the orange line underneath is when you take out glasses. Now, that is not to say that the need is less. It's to say that glasses and refractive error correction are really important, but then also this other area of assistive technology, which often is more complex to provide, needs to be paid attention to as well. So then we have this inequity figure. So it's true that, in a number of the population representative surveys, we saw really, really low figures of access, and 3% was the lowest. But, hovering around 3 to 7% in low-income countries tells us that we really do have an access issue. Then if we go to the next slide, where you can see that the data picture really changes as people age. So prior to the global report, assistive technology was very much seen as something that was an issue for people with disabilities. But actually the data shows up that the bulk of the users are older people. So people age 60 or over, 2 out of 3 are using at least one assistive product. And we see a really sharp J curve as people age and that they start to need more and more assistive products through maintaining their independence and then going into assisted living, palliative care, and so on. These products are really critical, and timely access is important. Then if we just talk a little bit about some of the access barriers and the access barriers and how people are accessing their products, and then the barriers to access. So this next slide shows you that 67% of people surveyed are accessing their assistive products through private shops or clinics. That in itself isn't necessarily a bad thing, except that we know that the regulation around assistive technology is very, very weak. And so when people are paying out of pocket and going to private shops, there's almost no protection around the quality of the products they're receiving. There's very little service delivery and very little aftercare. And that is not what we need in terms of good quality outcomes and good successful use of assistive technology. So again, it's an area that we really need to focus on. And then in contrast to that, the barriers are, of course, the high cost of many assistive products, and even products that actually at production are quite inexpensive. By the time they reach service users, they're very expensive. So there's the cost, there's a lack of support, there's a real lack of trained personnel to provide assistive technology, and very low availability. So, this photograph here describes a whole story around a young girl in an inclusive education in an one of the Pacific Island countries in the Pacific region. She's holding a white cane, which is really great news. But what you can't see in the photograph is that she was given that cane when she was 7 years old. She's now 13. So the white cane doesn't actually touch the ground. So as a device to help her to move around safely, it's absolutely useless. And getting her a white cane seemed to be a completely intractable issue in the island in which she lived. Yet the woman standing next to her is a very, very well-trained mobility assistant who can teach her how to use her white cane. So the issue for her was about supply chain and accessing that product, because there just wasn't the system in the country in which she lives. And then finally, in terms of findings from the data, we can tell you that, of course, the need for assistive technology increases during crisis. And I think, many of us, we know the situations that are going on around the world at the moment in terms of conflict. This is also an issue when it comes to climate change related disaster, or just plain climate disaster and floods, cyclones, etc. So we do see people losing assistive technology during the immediate effect of an emergency, but then we also see these huge increases of need due to the injuries. And I think I really want to sort of flag here that this, again, is not just about disability. It certainly is, but it is also relevant to people of all ages. And if you think about displacement and older people who are having to move in a hurry and then moving into shelter and don't have the supports around them, and then you see their functional needs become increasingly challenging for them. And if we can't provide support through assistive technology, then they are disadvantaged. Next slide. This next slide shows a beautiful spider web. And the key piece of information around this graph has come from the progress indicators that I mentioned earlier, where we asked member states, and 70 member states responded and shared with us their system preparedness to be able to deliver assistive technology. And the key message in this graph is that we can see some beginnings in terms of policy, legislation, some sort of budget provision beginning in many countries. But when it comes to the training, the workforce, the provision systems, there's a real weakness. So everything needs work, but this area around provision models is really important. I also want to flag, before I get to some key messages and the recommendations, this graphic on the left, which is what we call the 5P framework. It was a framework that's been developed by the assistive technology sector in collaboration with WHO. And it really talks about the ecosystem that we have to think about if we want to strengthen access to assistive technology. So we need to think about the service users in the centre, good person-centred care, and participation of people in the development of the services for their support. But we also have to think about this ecosystem of ensuring the right policy environment. And for that, we also include the finance mechanisms. So decisions need to be made about how assistive technology will be financed in a given country. We also have to think about the products, the quality, the supply chain, specifications, regulation, and then we have to think about the provision models, because you do not just provide assistive products by handing it out. There's an assessment, there's a fitting. Almost every product requires some level of user training and then follow-up. So we need the provision systems and we need the health workforce. And you start trying to talk about one area of these, and very quickly you're going to have to talk about them all. So it really is a jigsaw puzzle, and we need to think comprehensively when we're planning programs to strengthen access. So the next three slides, I'm just going to really quickly share with you a couple of key messages that we've taken at WHO from the global report and are really focusing on or wanting to raise awareness about. So the first one talks about integration of assistive technology across health systems. Now, this can also apply across other sectors like education, social welfare. But obviously from WHO, we're very interested in how we ensure that health systems are well prepared to provide assistive technology across the life course and across the different health interventions, and to make sure that that timely access is there. And one of our big focuses is really trying to push out to primary health centres to raise awareness, to build referral mechanisms, and also for provision of simple products like reading glasses, walking canes, walking frames, pillboxes, simple products that can be provided and can really improve people's quality of life very quickly. The second key message I just want to flag is around the enabling environments. We often get asked this, particularly in low-income countries. We get told, what's the point of providing a wheelchair if the environment is too rough, the terrain doesn't work? And of course, you still need to provide a wheelchair, but you need to think about the environment in which that wheelchair is going to have to function and the user is going to have to function. Essentially, I think about it as like a jigsaw. You need to think about accessibility at the same time as you're thinking about assistive technology. Where there's good accessible environments, the use of assistive technology is enhanced. Where you have good assistive technology, you're more able to cope with the type of environment that's around you. So it's a bit of you need to do action on both. And then the third key message is about investment. So we know that there is a good return in investment on assistive technology. You can see the slide here, $9 in $1 invested and a $9 return. That was a sort of global analysis that was done a couple of years ago. And then as Alexei mentioned, we've been working really closely with the task force on developing a methodology to better measure at the country level what the return on investment is in order to raise awareness and to support countries to advocate within the country for budgetary provision to support access to assistive technology. Okay, finally, here are the 10 recommendations. I'm not sure that I want to read them all out because that would become really, really boring. But what I do want to do is just flag that if you look at these recommendations, you can clearly see how most of them link in to that 5P framework that I talked about. So, you know, we've got the recommendation 4, which sits very, very well with the people P. Actively involve users of assistive technology and their families in everything about them, in the development of the services and in their own service delivery. And then we've got, for example, invest in data and evidence-based policy, recommendation 6, and you're going to hear about that in one of the case examples. So these recommendations really are about operationalizing aspects of the 5P framework. There's one recommendation which sits a little bit outside of that, which is recommendation 10. And again, I just want to thank the task force for bringing and convening you all as UN agencies, because this speaks to recommendation 10, which is about providing technical and economic assistance through international cooperation to support national efforts. And we all have a role to play. And in order for us to discuss that role to play, I'm going to stop speaking here so that I can hand over to the case studies. And then we have a little bit of time for some discussion to see where you feel as UN agencies, you may feed into some of these recommendations or where your role sits. So thank you very much. And over to you, Dorothy.
Great. Thank you so much, Kylie, for the overview of the global report and the 10 recommendations. We'll now share case study examples highlighting 3 of the global report recommendations. So first, Dr. Ahmed Azab will present work in Egypt related to the report's 3rd recommendation, which relates to building workforce capacity. Second, we'll hear from Mr. Oscar Mirandez, who will present work from Colombia related to the report's 6th recommendation, which is enhancing assistive technology data collection. And finally, Ms. Tatiana Bereshuk will present work from Ukraine related to the report's 9th recommendation, access to assistive technology in humanitarian settings. So I'm just going to change my slides. So Dr. Ahmed Azab is our first presenter. He is the coordinator of the high-level National Multisectoral Committee of the Presidential Initiative on Locomotor Disabilities. So thank you, Dr. Ahmed, and please begin your presentation.
Hello.
Hello, we can hear you well.
Good afternoon, everyone. Yeah, it was my pleasure to be here with you. And it's really nice to Egypt to be one of the case studies that is included in this webinar. I will try to go through my presentation as fast as I can to be within the time limit. However, at the beginning, I just want to thank everyone working with WHO, UNICEF, because they are helping us a lot, especially Kylie, which already here is with us. This is about our national project in Egypt for improving life of people with locomotor disability. So next slide. course, the main part of this project that we are faced is about the personnel or the human resources. We faced a lot, and when we go through the presentation, we will find that when we doing all assessment, we found that the big gap or the minimum score are we going in the personnel. So what we did is a lot to improve that, which is, of course, is coming with recommendation number 3 for the global report on assistive technology, how to improve and enlarge the human resources capacity. So next slide, please. So we started this project under some rationale, which is the UN Convention on Right of People with Disability and our Sustainable Development Goals for 2030. The high political commented due our new health coverage system that is already started in Egypt 2 years ago and should go through the whole Egypt in 2030. And then how to reduce the magnitude of this problem of people with disability, which is due chronic disease, aging, or any other region any other reason in Egypt or in the region, in order to reduce the burden of disability, social, psychological, or even financial. So next slide, please. So our aim at the end is to have a national project that will provide high-end quality product and even the finance service. So not only products, but product and service to all Egyptian and non-Egyptian around in the region. So to become productive, independent, and again, active participant in society. So next slide. Next, please. So the main part of the complex or the project part is about how to localize production or manufacturing of assistive. No, the previous one, please. Sorry. Yes, this one, sorry. So it's a two-part. Part is about the manufacturing of the assistive technology product related to locomotor disability, which is prosthetics, orthotics, medical shoes, wheelchair, fabrics, and silicone products. And the other part is about service provision, which include medical engineering service, rehabilitation center, 47 fitting center around the whole country, training center, R&D center of excellence, and the ISO testing lab. So next. So we started to find our gaps when we do the prosthetics and orthotics standard assessment in Egypt in collaboration with WHO. And if we found that we have a huge gap in the part of the service provision and in personnel, which start us to work on it. So the lowest score we got is around 12% in personnel. So next. And also this why, because all the people that are, or personnel that are professional are only in the Cairo, which is the capital. So the main 3 centers working with assistive product or assistive technology related to locomotor disability are only in Cairo. And all people from the whole country have to travel maybe around 12 to 14 hours maximum and minimum 3 hours to go to Cairo. So our plan was first is to make a mobility center distribution around the whole country with 47 centers in every governorate. So now all the country are covered with the service centers as a building, as equipment, and then we need to invest in the personnel and service provision. So next, please. So then first thing we have applied is TAP. So now TAP training is a mandatory for all health provider in the new health insurance. So we already did TAP training for 6 governorates, which already has a new health insurance. And because we know about TAP, this after we launched the new health insurance, all 6 governorates starting TAP after already being in service or medical service. But now anyone working in the health service provision before going to the new job, it's mandatory to go through all TAP training and then get the new job. So next. Okay, especially for wheelchair. After we did the assessment, we found that in Egypt, we don't know anything about customization and the fitting for wheelchair. We only know about two types of wheelchair in Egypt at that time: standard wheelchair and electrical wheelchair. So if all people mostly get the standard wheelchair, and if you want to do a favor for someone with disability, you prescribe an electrical wheelchair, which you found that it is wrong and it's not anywhere in the world. So with WHO collaboration, we start to
Este no es el
do
caso. Entonces, con
wheelchair
la
training. So we
colaboración
start,
de
we get
la
16
OMS,
persons
empezamos
from
con la
all of
capacitación de sillas
service
de
providers in the
ruedas y
country,
trajimos
not from
16
only one
personas
place,
de
but
todos los
from 6
proveedores de
places.
servicios del
We cover
país.
all the health provider, and we start to go with the basic level of wheelchair training. So next. Then we start to do awareness across the Ministry of Health and Social Solidarity. So we do that for physician, physiotherapist. We do around 4 or 5 rounds now. So 4, we already completed 4, and we are now in the 5th round to spread the awareness and the knowledge about wheelchair, fitting, customization, prescription, everything related to wheelchair. Next. Then we do the same thing for social solidarity service provider and NGOs, how to spread the awareness about that. Then, next. So here what we updated in the 5 Ps that mentioned in Kylie presentation. We work about policies, provision, product, personnel, and people. So we did a lot of policies. We launched the EDA, or the first edition of the national list to regulate all product important from outside. Now we have a document under revision by the Prime Minister to regulate the market for mobility assistive devices. We have guidelines, database now that connect every service provider for that part. We have now guidelines for dispensing and using and the duration. Quality standard has been set for all mobility aids and devices, and for human resources, which is the main part. We have now job classification and objective. We have inclusion of female in all prosthetics and orthotic centers and wheelchair training. We have included the MDT, or multidisciplinary team scheme and approach, in our new health system. We have now include wheelchair training in all universities like physiotherapy college, B&O college, physician, or related to service provision for assistive technology, and now that have become mandatory for all health providers in the new health system. Next. Now, based on the recommendation 3, we are now collaborating with WHO and ISWB to train and certify the 16 individuals that already go to the basic training, to go through the intermediate training, TOT training, and then Egypt to become a hub for
Thank you. I think
become
we
a trainee or become a hub for IWSP related to the.
Wonderful. Thank you, Dr. Ahmed. Very, very interesting. And apologies, I think we just lost the sound there right at the end. But thank you very much. So our second presenter is Oscar Marin Diaz. He's an advisor and coordinator with the Medical Devices and Ionizing Radiations Group from the Ministry of Health and Social Protection of Colombia. So thank you, and please begin your presentation.
Gracias, buenos días para todos. Esta es una presentación muy corta de
It's a very
del
short
trabajo que hemos hecho en
presentation,
Colombia alrededor
the work
del
that we have done in
sistema
Colombia on
Siguiente, por favor.
support technologies. Next, please.
Entonces, como lo veíamos en la
So,
primera
as
presentación, esta
we
es
had
una
seen
de
in the
las,
first presentation,
de las
this
recomendaciones. La
is
recomendación
one
6,
of
que
the
estamos hablando
recommendations,
de
recommendation number
cómo
6, that
hacer
we're talking
recuperación
about
de
how
qué
to
datos son
do
importantes
data
que
gathering, what
representan
data
dentro
is
de la atención de
important,
salud
that
y
has been
del
seen within health
alrededor de la
provision
tecnología de apoyo.
and around
Hay
support
una
technologies or
necesidad
assistance
de conocer
technology.
cómo están
There's
las
a need to
tecnologías que
learn
vienen siendo usadas.
about how
Entonces,
technologies are being used right
en
now,
apoyo también con
and in
OPS hemos diseñado
support
una
with
serie de
PAHO,
actividades
we've
que
designed a series of activities
estamos
where
en pro de
we
recibir
are
el informe final en los próximos
now
días. Es
pending to receive the
un trabajo
final
muy
report in
interesante
the upcoming
del
days.
cual
It's a
al
very
final
interesting
le
piece of
vamos a
work
hablar un poquito.
where
La
at the
siguiente.
end we will be talking about a bit. Next, please.
Colombia tiene una diversidad grande
Colombia
de
has a
sus
big
regiones, digamos que en
diversity in its
términos
regions, and
grandes está dividido en 6 regiones. Si
it's
ustedes pueden
divided
ver,
in 6
como es el
regions,
centro,
as you
siempre
can
están las
see.
montañas, es una
Within the
región muy distinta
center,
hacia la
oh, the
Caribe,
mountainous region is very
Pacífico,
different than the
y
Caribbean, the
abajo tenemos
Pacific,
Amazonía,
and
Orinoquía.
at the bottom we
Tenemos,
have
como pueden ver,
the Amazon
una
region and the
gran diversidad
Orinoquia, and these are regions that have a
regional
great diversity in their
del,
people,
del acceso a los servicios
and
de
the
salud en todas las regiones
access
es muy
to health
distinto. Digamos
services
que
in
tenemos
all the
una gran
regions is
concentración
very different.
hacia el
We have a
centro del
great
país, donde está la
concentration
capital de
towards the
una
center of the
serie
country,
de
where we have the
ciudades
capital
grandes y
and a
departamentos que
series
tienen la
of large
capacidad
cities
de
and large
poner servicios de
departments
salud a disposición de las
to
personas,
put health
y hacia
services
lo que es la
and make them
región
available for
Amazonía,
people.
que
And
es hacia el
also
sur del
in
país,
the Amazon towards the
tenemos
south of
una
the
gran
country, we
disparidad
have
entre todas las
a
personas
big
que estamos
disparity between
necesitando
all the people
tecnología
who are
tecnológica.
needing
Siguiente.
assistance technologies. Next, please.
Esta es la reglamentación grande, digamos que
This
nosotros
is
somos
the
un
big
sistema de salud que está
regulation. We
concentrado
are a health
en la
system that is
organización de
concentrated
unas,
in the
nosotros los llamamos
organization
EPS,
of, we
pero
call them
son
EPSs, like
entidades que
HMOs.
aseguran a
And
la,
these
la
are
población, y
entities that
dentro de esas
ensure the
prestan y
population,
brindan los servicios de salud.
and within these, they
El decreto que
provide
vemos acá
health
en negro
services.
es el
The decree
4725, que es
that
el
we
del
see
que se
here in
desprenden todas
black
las
is
tecnologías
4725, which is the one
que son
that
considerados
all
dispositivos médicos,
assistance
y bajo la
or medical
cual
devices
es la
technologies
puerta de entrada a
stem
ser
from, and this is
proveídas
the
por el sistema de
entry
salud.
point
Vemos
for
que
them to be provided by
este
the
es
health system.
un
This
pilar
is a
fuerte para la
strong
identificación de
pillar
seguridad y calidad de
to
las
identify security
tecnologías
and
que van a ser
quality
consideradas
of the
dispositivos
technologies that
médicos.
will be considered medical
Siguiente.
devices. Next, please.
Y adicionalmente tenemos
And
unas
additionally,
tecnologías que
we
son
have
también dispositivos
technologies
médicos,
that
pero
are
que son
medical
diseñados
devices,
sobre
but that
medida.
are
Vemos que
designed
estas son
custom.
tecnologías prescritas por el
These
médico
are prescribed
para
technologies
hacer
by a
una
physician
intervención específica en un
to
paciente.
do a
Y estas
specific
tecnologías
intervention on
tienen
a patient, and
un
these
fin
technologies
de
have
permitir que el
a
paciente pueda
purpose
recuperar
where
o se
they
cuide de una
allow the
deficiencia
patient to
de
recover
su,
or recover for a
de su cuerpo
deficiency
generado
in
por
their body
discapacidad, y que
generated
ésta
by a
tenga
disability, and that
una
it could
mejor
have
adherencia, una mejor,
or that they could have better
suplir
adherence,
mejor esa deficiencia. Estas son
or that
tecnologías que
it
se
can
diseñan
cover
a
this
partir
deficiency more.
de
And these are
el estudio
technologies that
y
are
la
designed based on the
concentración de un
study
paciente
or the
específico.
concentration
Entonces
of
tenemos
a
tecnología
specific
ortopédica
patient.
externa,
So we have
tecnología
external orthopedic
visual y ocular,
technology,
y
visual and
auditiva. En estas
ocular
tres es en
technology,
las
and
que
auditive
nosotros nos
technology. And
podemos
in
centrar
these three
sobre
is
tecnología
the ones that
tecnológica.
we
También
could focus
estarían
on assistance
las
technologies, and
siguiente,
we
por
could
favor,
also
la
have,
siguiente diapositiva.
next
También
please, next
tenemos
slide please.
la
We also have
sobre medida para dispositivos médicos bucales, que
custom
se tienen centrar
vocal
dentro de
medical
las
devices.
deficiencias que tiene el cuerpo, pero
And this is also focused on
tenemos
certain
las tres
deficiencies in the
principales, que
bodies, but
serían
we have them three main ones that
ortopédica
would be
externa, visual y
external
ocular.
orthopedic,
En
visual,
en
and
esas
ocular.
reglamentaciones
And
se dan
in these
directrices de cómo
regulations,
acceder al sistema
we
de
have
salud, de
guidelines on
cómo,
how to access to the health
de
system,
quién es el
how
personal que debe hacer la
or
evaluación,
who is
y
the
quién es el
person who
personal que
must do the
debe
evaluation,
hacer
who
la
is the
adaptación de la
person
tecnología
who
para
should do
entregársela
the
al
fitting
paciente,
of the
luego de
technology
que
to
ha
give
sido
it to the
fabricada
patient,
con unos
and then
procesos que han
after it's
sido
been
verificados
manufactured
por la Agencia
under
Sanitaria de
processes that
Colombia.
have been verified by the
Entonces,
Colombian Healthcare
estas
Agency, which
tres
is INVIMA.
características entran
And these
como
three
parte del sistema:
characteristics
la evaluación de
are a
calidad
part of
y
the
la
system,
autorización de los
the quality
establecimientos
evaluation and
que
the authorization of the
proveen la
establishments
tecnología
that
al paciente.
provide the technology to the
Siguiente.
patient. Next, please.
¿Cómo hacemos la identificación de las personas? Colombia
How do we
tiene,
do the
digamos que hay
identification of
un
the people?
hito en
Colombia
el
has
2020. Teníamos
there was
primero
an
un
important milestone in
registro
2020.
de
We first
localización
had a
y
registration to
caracterización de
locate
personas con
and
discapacidad. Esto
characterize
que
people with
llamamos antiguo,
disabilities. This is what we call the old
registro,
one.
lo que se basaba era en una
And what this
declaración de la
was
persona.
based on
Yo
was a
me
statement on part of the
autorreconozco como una
person.
persona que tiene una
I
discapacidad,
see myself or
y
recognize
eso
myself
lo
as a
habilitaba
person
para
with a
acceder a ciertos
disability,
servicios.
and
Y
this
entonces muy
enabled them
2020, y
to
eso
access
fue
to certain
un
services. And in
cambio de
2020,
esa
what we
forma en la
did
que hacemos
was a
ese
change in the
reporte,
way
y
that
ahora
we did
requiere una
this
evaluación por un
report,
médico
and
que
now they need
evalúa
an
realmente
evaluation from a
cómo es,
physician that
cuál es su
actually
grado de
does
discapacidad.
assess their
Y
degree of
en
disability.
es el que hemos llamado,
And
pues aquí lo tenemos como un
this is
cambio
what we
nuevo
have called, or here's what
de esa
we've called this,
discapacidad,
like
y ese es el
a
mecanismo que
new
habilita
change.
para que
And
estas
this is the
personas puedan
mechanism
acceder
that
dentro del
is
sistema de salud
enabled for the people
a
to
los
access within the
servicios de
health
apoyo.
system to their assistance technologies. This is not only a change in going from like a recognition of the person to actually assessing who are the people that will require this and be able to have them within a system or to follow up for their rehabilitation so that they can really access the services. And then at the end, we have information that we see on the right of how many people have accessed the visual aid technology system, and we have 1,465 people. And for other technologies for mobility, like canes and wheelchairs and walkers, 510. And for auditive, like medicated earphones and cochlear implants, we have 1,120. And here we also need to understand that the hearing aids are an interesting case for the Ministry of Health because they go within price regulation, the National Commission uh, price for medication medical devices has select codes. We know that the free that we have all the prices of all the vendors, and then with that, the market regulates its prices naturally. Next, please. How do we, for the patients, there's two mechanisms. The first one is that this technology is within the health system, and for it to be within the health system, I was telling you that it needs to be considered a medical device. So this would be focused mainly on these three characteristics for mobility, hearing, or vision, and this is paid by resources from this system, and or it would go within assistance technology banks, where the country has 116 departments and municipalities that provide with its own resources, with the other sources from the social sectors or NGOs, and they deliver support technology or assistance technology to the patient that needs it. Next, please.
Entonces, de esos 35
And from
dispositivos
these 35 devices or technologies that are described by the WHO, the health system recognizes 15 that are devices such as medical devices. So here we see some characteristics, and these are paid by the health system. For example, 15th would be paid by the sector of the Ministry of ICT because it's a screen magnifier. Next, please.
En cuanto al personal, encontramos que tenemos
And
una
in
gran
regards to
cantidad de
personnel, we
personal que
found
está
that we have a
dentro del
lot of
sistema
people
reconocido
who
como
are within the system
personal de salud,
recognized
y
as
estos
health
pues están
personnel,
distribuidos alrededor de
and they are
todos los servicios que
distributed
tienen los proveedores
around
de
all the
servicios de salud
systems
en el
of the health
territorio colombiano,
services
y hacen
providers in
parte
the
de un
territory,
registro
and they are
especial del
part
prestador
of a
de
special
talento humano en
registry
salud,
of
que se conoce como RETUS, y
human
esos
talent in
estarían
health
mapeados. Por
providers,
ejemplo, tenemos
and these would
aquí
be
es
mapped.
interesante como en el
For
caso de
example, here
abogados
it's
especiales
interesting
que como no
that
hacen
we
parte
have
del
a case
entorno del ecosistema del
where
sistema de salud,
some people are
no
not part
tenemos
of
datos,
the
pero
ecosystem of the health system and we
los
don't have
ingenieros
data.
biomédicos
But for
estarían al
example,
margen de
biomedical
todo este
engineers
tema
would be
porque
left
si
out
bien
of
son
this
necesarios
because
para
while
la
they are
fabricación y
necessary
el
for
mantenimiento
the
de ciertos
manufacturing and maintenance
dispositivos y equipos
of certain
biomédicos, no están
devices and
considerados
biomedical
del
equipment, they are
sistema de
not
salud
considered
y o personal
part of the health
de
system
salud y
and
ese no
or
estaríamos
health
regulando.
personnel,
Simplemente queda
and
como
we would not be
información
regulating them.
que
It's
proveen para
just
su
in the
formación desde el
regulation that is
sistema
provided for their
desde el
training
Ministerio de Educación Nacional.
from the ministry, from the
Siguiente.
National Ministry of Education. Next, please.
Y finalmente, estas son parte
And
de la
finally,
información que
this is part of the
recibiendo
information that we will be receiving from
la
PAHO,
consultoría que nos han hecho en el sistema
from the
ATAC,
consultancy that they've done
y
on the
en
ATAC
primer
system.
punto quiero,
And
como
first
tomar en
point
cuenta el
that
tema
I want to keep in mind
de
is
necesidad de
the need to use the tool to recover key data from these populations that require the information and that require the support technology, and what's the level of access? How are we seeing the gaps? What have people been able to do to access this assistance technologies, and what's the difference in access between urban and rural areas or from the center to the periphery of the country? Evidence-based policies, we have a health care system that provides technologies within a set that is called the health benefits plan, and the idea is to be able to boost and integrate more of the people within these policies, within this support technologies for the needs that the population is actually having. We have a need for all the data that we've generated within the health system. This is not just for assistance technology. And the health system generates a lot of information that from the Ministry of Health, we know that we have to start integrating within several systems. And these are one of the policies that are designed or thought within the National Policy of Medical Devices, which is a resolution that came out this year, and that we are promoting also a second phase for the policy of pharmaceutical products and medical devices that are being formulated as a government policy with many sectors in the country in what is known as a COMPES document. And also the need to establish mechanisms to share information. This is necessary for each one of the patients to understand and tell what their experience has been like, and that this is necessary to improve the access to health services. Thank you so much for this space. And I hand back the floor to you. Thank you so much.
Wonderful. Thank you. Very insightful. Thank you, Oscar. So our third presenter is Tatiana Bereshuk, Associate Professor in the Department of Physical Therapy and Occupational Therapy at the Cortezia National Academy, and she's the board chair of the Ukrainian Association of Physical Therapists. So thank you, Tatiana, and please begin your presentation.
Hello, everybody. Appreciate to be here with you. Try to be short in my presentation, and first slide, please. And in this presentation, I will share an example of action carried out in Ukraine, meeting recommendation 9 from the global report on assistive technology to include assistive technology in humanitarian response. And the example showcases a project implemented in 2022 and 2023, enabling rapid access to essential assistive technology in Ukraine. Case stakeholders involved in the project include WHO AT team at headquarters, WHO Regional Office of Europe, WHO Country Office, Ukraine, Ministry of Health, Social Policy, Ukraine and local government, Group of Active Rehabilitation and Kyiv International Institute of Sociology. And the project was made possible throughout the support of AT-Scale, Ukrainian Humanitarian Fund, Swiss Agency of Development and Cooperation, Ministry of Health, Germany, and the European Union Directorate General for European Civil Protection and Humanitarian Aid Operations. A lot of stakeholders we have. And firstly, about recommendation 9K action. We remind ourselves the evidence put forward the global report, and it's improve the quality of life, safety and protection of people with newly infected or pre-exciting functional difficulties, increase community ownership, stability and support peace-building processes in post-conflict situation, also mitigate the consequences of fragility, conflict, and violence. And under recommendation, under this recommendation, we have 4 point actions. Its essential assistive products can be included within the essential healthcare supply and alongside trauma emergency surgical kits. We're talking about training material focusing on task sharing and adaptation, translation rapidly. Integrated provision of appropriate services can be set up to ensure the assistive products and related services and compatible with those to be used in the long term. And the last step is the emergency response facilities should be barrier-free and inclusive. The next, when we talk about the first section, essential assistive products, the WHO AT team, in partnership with WHO Regional Office for Europe, WCO Ukraine, and the Ministry of Health of Ukraine developed a project to support assistive technology needs of people affected by the conflict in Ukraine, primarily internally displaced and refugee populations. WHO has developed IT-10, a kit of 10 essential products, including walking aids, wheelchairs, and self-care products to support internally displaced people and refugees. Each kit includes 1,200 assistive products to meet the estimated need of 10,000 people. The product breakdown at the IT-10 kits for Ukraine were developed specifically for the context, it was drawn in on in online survey 2022 to identify priority assistive products for humanitarian response. It was anecdotal evidence from Ukraine, stories requested, and rapid feedback from case stakeholders also. The next one. The project was implemented in 2 phases. It was a course of 2022 and 2023. During these phases, over 8,000 assistive products was procured as part of IT-10 kits and were distributed to health facilities in K oblasts in eastern Ukraine. The quantities of individual products in IT-10 kits list were adjusted in the second phase because it was we have a request for transfer boards and bus boards, and there was added. And learning was documented for future also. The next one, what about training materials? Training in assistive products, it was a TAP, is a free interactive learning resource that teaches how to provide simple assistive products through the 4 step. These 4 steps was a select, feed, use, follow up. Modules in this online service cover 6 domains: mobility, self-care, vision, hearing, cognition, and communication. And TAP modules in mobility and self-care were used to support the product included in IT-10 kits. In addition to a new model piloted to the first time in Ukraine, it was wheelchairs in emergency. And since the project, WHO team have also developed an introductory model and assistive products in emergencies also. Next one. We use 8 modules that was rapidly translated. They include introduction to assistive products, mobility assistive products, walking aids, self-care assistive products, toilet, shower chairs, absorbent products, wheelchair and emergency, and transfer boards. It was added for the second phase. It was so we have 84 learners that took part in tape models. There was all from 14 facilities from 8 regions, most affected Eastern region. And there was 5-7 learners from each facility. Also, there was 22 mentors supported the learners and implement TAP and provide assistive products in their respective clinical settings. And in most cases, it was 2 mentors from the facility. Next one. The third action integration, 80-10 products were provided through personal undertaking TAP models from rehabilitation department, exciting health facilities. And there was to ensure people receive the most appropriate product, could use it safely, effectively, and where possible, referrals were made for further care, rehabilitation, and follow-up. And learners and mentors all represent rehab professionals. There was physical therapists, occupational therapists, the assistive, and doctors of physical and rehab medicine, mostly. Support and engagement also was from the Ministry of Health of Ukraine, and locally we have a support from educational institutions, healthcare facilities, and also administration of internally displaced persons communities different. And next one. And existing health facilities providing assistive technology all had rehab departments and had appropriate access as ramps, lifts, spaces for selecting and fitting devices. It was very important for us. Facilities had transport accessibility, although learners and mentors observed some access challenges from range of users, and it wasn't able to travel to facility location. And all process was documented. And thank you, I'm on time. We talk about the 3,000 people that really have 80 technologies, assistive technologies they need during these 2 phases of our project.